So I'll be presenting to us a case, a unique case that we managed with Dr. Sokwala, among other people. It was a multidisciplinary management, including the nephrology team, endocrinology team. We had the pathology department and the radiology departments involved as well. So just go to the next slide. So it's a case of a 38-year-old male gentleman who was known to have diabetes mellitus from February 2021, and he had been put on Lantus 16 units and vildagliptin, metformin 5500 once a day. So he presented to us on the 19th of May 2021 with a 4-day history of vomiting and diarrhea, which were associated with reduced urine output, reduced appetite, and I also noticed reducing insulin requirements. He reported to us that his last insulin injection was 2 weeks prior to presentation to us. His past medical surgical history was significant for an admission in February 2021 with acute pancreatitis secondary to alcohol use. So on examination, he was moderately dehydrated and had pallor. His blood pressures were elevated at 157 out of 90 millimeters of mercury. His random blood sugar was 3.8, low at 3.8 millimoles per liter, and he had ketonemia of 2.7 millimoles. An arterial blood gas analysis showed metabolic acidosis with a pH of 7.1 and a bicarb was of 10. His potassium on the gas was 5.7. And his ECG showed peaked T waves, which was consistent with the hyperkalemia. So we did urea electrolytes and creatinine, which was remarkable for elevated serum creatinine at 1,206 micromoles per liter. Urea was high at 36.7, and this sodium was low at 125. He also had hyperkalemia, which confirmed the potassium level that had been shown in the blood gas. Of note is that his baseline creatinine, that's the creatinine from the previous admission, the admission in February, was normal at 99 micromoles per liter. His complete blood count was remarkable for microcytic hypochromic anemia with a HB of 5.8. His UACR was, however, normal. I want us to take note of the UACR in the background of diabetes. It will inform our next discussion. Let's go to the next slides, please. We did other tests. HbA1c was at 5.54%. His phosphate was high. He had features, generally had features of iron deficiency with a TSAT of 14.7 and bone mineral disorders with all those things that we can see. His urinalysis, I also want us to take note of that. He had no hematuria and had no proteinuria. And remember, he's a diabetic patient. We did a renal ultrasound that showed features suggestive of bilateral renal parenchymal disease. So at this point, we had impressions of acute kidney injury with the differential diagnosis of acute on chronic kidney disease in view of the ultrasound findings and the laboratory parameters which were consistent with the bone mineral disease. Microcytic hypochromic anemia, he had a HB of 5.5. We were querying blood loss, which he had not reported to us though. And euglycemic ketoacidosis, he had his laboratory parameters sort of were consistent with diabetic ketoacidosis, though his blood sugar was slightly within the normal range, we could say that. He had high anion gap metabolic acidosis. His ketones were raised at 2.7 millimoles per liter. And because he had history of vomiting and diarrhea and his intake had been impaired for some time, we're also thinking of a differential of starvation ketosis. His blood pressure was elevated at 157/90. It had been elevated for more than 6 hours from the point of contact to the several readings that were taken in the ward. So we gave him a diagnosis of hypertension. what did we do? We admitted him, we started him on urgent dialysis, insulin therapy with dextrose normal saline infusion. We transfused 2 pints of packed red blood cells, supplemented vitamin D, gave him Meditrol 0.25 micrograms once a day, and amlodipine for hypertension. For blood pressure control, 5 milligrams OD. On further evaluation, we did a CT KUB that showed, you can see it's an axonal view that showed hyperdense features of hyperdense areas that were consistent within the pancreas, that were consistent with calcifications, and that was suggestive of chronic pancreatitis. And he had suffered acute pancreatitis in February 2021. Next slide. So would you biopsy or not biopsy? How many of us will biopsy, would have biopsied this patient? How many will biopsy? Of course, I know Dr. Sokwa. Okay, so whenever you are presented to a case of a diabetic patient with renal dysfunction, there are certain things that you need to look at which will inform the decision to biopsy the patient. So one of them, the duration of the disease of the diabetes. If it's less than 5 years and they have renal dysfunction, then you need to think of an undiabetic kidney disease in the background of this diabetes. If they've had rapid progression of kidney dysfunction, like in the case of our patient, he had normal renal functions in February, and 3 months later, he presented to us with creatinine of 1,206, and that was quite a rapid deterioration. If they have microscopic hematuria, again, that will point towards a glomerulonephritic pattern that could be non-diabetic in origin. If they have abnormal serologies suggestive of another glomerular lesion, and we know all those serological tests that we're talking about here. If there is absence of hematuria, again, our patient did not have. If there's absence of proteinuria, again, his USCR was within normal range, and his urinalysis was not remarkable for proteinuria or hematuria. Then the last case is the absence of other microvascular complications like retinopathy and neuropathy. Then you'll think of an undiabetic kidney disease. There's a study that was done looking at the biopsies of diabetic patients who had renal dysfunction. And they found that a number of them had non-diabetic kidney disease. And of note is that 20% of them had other diseases other than those ones that have been mentioned. And oxalate nephropathy would fall within that category. So as a few of us had said they would biopsy, we went ahead and biopsied the patient after discussing with the patient and all the other teams that were involved in his management. And it showed, you can see the high power on the left, and then the polarized slide microscopy on the right that showed multiple crystals that were consistent with tubular crystals and interstitial damage from oxalate. So what is oxalosis? How does someone end up with oxalate nephropathy? So oxalate is an organic salt. Its sources are likely we can get it either exogenously from diet or endogenously as part of glycosylate metabolism within the liver. So hyperoxaluria occurs when you have urinary oxalate excretion exceeding 40 milligrams per day. The normal is about 34. That's 10 from the diet and 24 from the glycosylate metabolism. However, when you get excretion exceeding that 40 milligrams per day, then there is formation of the oxalate crystals within the tubules and within the interstitium, causing both tubular injury and interstitial fibrosis. So what are the types of hyperoxaluria that someone could end up with? We have 2 types, primary and secondary. Primary is where we have mainly genetic, it's as a result of genetic defects. And secondary hyperoxaluria is as a result of other sources, including excessive dietary intake of oxalate. This is how we had said that the endogenous production of oxalate is mainly from glyoxylate metabolism. So you can see on the far right, where you have the oxalate, you can see where you have the lactate dehydrogenase. So normally we have the glyoxylate being broken down, being transformed into oxalate via the lactate dehydrogenase. And you can have the same glyoxylate being translocated into the peroxisome or into mitochondria and broken down further into some other substrates. So if you have deficiencies of all those enzymes that are marked in red, then you end up with oxalate accumulation. Like, for example, if you have deficiency of that first enzyme, that will give you type 1 primary hyperoxaluria. Then the second one is that one that is also marked. I don't want to get into the names. You can go and check it out. That will give you type 2, and type 3 happens within if there's a deficiency of the enzyme that mediates, that catalyzes the breakdown of the hydroxypyruvate into all those things that you talk about within the mitochondria. So for our patient, the problem wasn't primary. He had acute pancreatitis and ended up with chronic pancreatitis. So how did he end up with secondary hyperoxaluria? So in a normal person, we get around 100 milligrams of oxalate from diet, and 90 milligrams of that is excreted in stool, and we have only 10%. That translates to about 10 milligrams being absorbed into the circulation. The 10 milligram combines with the 24 milligrams from the endogenous pathway to give us 34 milligrams that is excreted renally. So for our patient, normally, what happens, you have in a normal functioning pancreas, you have the production of the exocrine enzymes that mediate fatty acid or lipid metabolism. And as a result, you have the oxalate within the GIT, the oxalate that is excreted as 90 milligrams, the oxalate combines with calcium within the GIT, forming calcium oxalate. And that is not readily absorbed through the GI tract. However, in acute or chronic pancreatitis, you have impaired exocrine function of the pancreas, leads to accumulation of the fatty acids within the GI tract. And the fatty acids bind to the calcium instead of the oxalate, forming a complex between calcium and the fatty acids, leading to malabsorption. So you have no calcium left to bind the oxalate within the GI tract, and that makes the oxalate readily absorbable through the GI tract into the system. And that's what happened in our patient. There was a study by Columbia Renal Pathology Laboratory that was looking at diabetic patients with non-diabetic kidney diseases, and they took about 2,265 kidney biopsies, and out of that number, 22 of them had oxalate nephropathy. That was 1%. And the presentation was largely acute kidney injury, so acute kidney injury, those who presented with acute kidney injury was 38%, and the other 62% presenting as acute on chronic kidney disease, where we think our patient fell at. And the commonest cause was malabsorption at 72%, with excessive oxalate precursor intake at 14%. 52% of those patients had actually progressed into kidney failure requiring renal replacement therapy within a month. There was another paper by Nutha that was also looking at the presentation of those patients with oxalate nephropathy, and most of them had actually presented in acute kidney injury. That was, yeah. acute kidney injury, with only 29% presenting in chronic kidney disease. So how does oxalate cause nephropathy? So accumulation of oxalate, when you have excess excretion of oxalate through the kidneys, it leads to accumulation of oxalate salts that are deposited within the tubules and also within the interstitium, causing tubular injury and interstitial fibrosis. And after making a diagnosis, what do you do? It mainly depends on three things. One, the underlying cause. Like for our patient, the cause was chronic pancreatitis. And if you identify it to be as a result of excessive intake, then that's what you advise the patient to limit the precursors of oxalate. Secondly, it depends on the stage of renal dysfunction. Like for our patient, he had progressed quite a lot and he required dialysis at presentation and has remained on dialysis till now. Is on thrice weekly hemodialysis, among other managements that we are doing. And thirdly, it depends on other conditions that they are having that you could manage. Like, for example, there are supportive therapies that you can give the patient. If they have diabetes, then that's what you'll continue managing. That if they're at early stage, then the compounding effects of diabetes are also limited just by proper management of the comorbids that they're having. And I would like to say thank you to Dr. Sokwala, Dr. Anderson Mutwiri was the renal pathologist, and Dr. Hanika, the radiology resident who we are writing this paper with. Thanks a lot. And thanks, Dr. Twahir.